MMF lightly. Now who's moderating? It's Dr. Jyotsna, Dr. Rajlakshmi and Dr. Marvi, please. Keep the conversation going. You can
So this is
comment,
MMF light.
ask, criticize, whatever. Okay.
Dr. Esther, what is the percentage of TCA in this?
I'm sorry?
What is the percentage of TCA in this?
15% TCA and 8% phenol. Now I want the camera to be focusing. I hope it is.
How do you prepare this 15% TCA?
I am not preparing it, I am buying it.
Okay.
This particular one is Sesdama and Sesdama is not sponsored. Okay.
Dr. Esther, do you want to throw light because this topic of preparation has come?
Close your eyes.
How does it differ? Like because people sometimes in government medical colleges like when we used to study do a post graduation,
Yes.
we used to prepare TCA. Of course, we used to use it for other purposes, for molluscum and all. But what do you think would be the difference if we dilute the TCA crystals versus the Sesdama 15% TCA?
Now, this is got a host of other things other than the TCA, and also compared to various other TCAs, I like this one because it does not frost. You will observe that even after, now we don't have that much time, so in 4-5 minutes we are going to be neutralizing it, but this is not going to frost. So the downtime is very less and the safety margin is very high. The problem with this crystal thing is that one, it can have only pure TCA, the measurements and all sometimes are not great, and it tends to be very aggressive. So it is okay for maybe a Xanthelasma palpebrarum or a TCA cross kind of a thing, but for such things I would not recommend something that you would compound. So I had applied one coat all over, and now I am going to be, basically his AL is localized to his lower lids. So I am going to be applying there. Now we thought we'll show something as simple as a peel because I don't know how many people do eyelid peels. And there is a method and a process of doing it safely. So you saw that I asked him to look at the ceiling and apply the lower lid, and then he's not going to open his eyelid till I tell him.
Ideal priming agent in such cases.
Sorry?
Ideal priming agent you recommend in such cases.
For him, now he is someone I am meeting for the first time, but generally I would give a retinol. A 0.05% retinol is what I would give.
Plain retinol or any combination with hyaluronic acid or any other?
Hyaluronic acid in the moisturizer, I am actually not aware of any retinol hyaluronic acid combo eye creams. So
nowadays we have a little bit of hyaluronic acid, ferulic acid and retinol combinations also available in the market.
ferulic acid combination is something that works quite well for these periocular areas. So most of these are proprietary preparations and we generally don't use brand names here. But generally I think combinations are the way to go. Now eyelids tend to have thin skin. A lot of people don't tolerate these well. So you want to use a micronized formula typically, sometimes a nano formula. So,
Dr. Esther,
So we have
frost
already-
is visible actually. Probably
Sorry?
if you can slide
Little
frost
bit
is
of
visible.
frosting
Yeah,
is-
you can stretch this.
I think it's-
able to see.
Slight
Slight
frosting is
frosting.
coming, so we can utilize. It's been 2 minutes and 29 seconds now. So what I'm going to do is I'm going to utilize off. Anyway, our area of concern is the lower lid, so I'm going to be first
Is there any other thing you recommend or only TCA is the better option?
For acanthosis nigricans, I like to do this. These non-peeling peels don't do much for acanthosis nigricans. And this was the peel that I had used in both the patients whose pictures pre-post I had shown. And both were the result of, you can see the frost here. Close your eyes. You can appreciate it on camera.
Yeah, we can.
Okay, so we already have these cotton pads ready. My able assistants have kept it ready, and we also have saline because it can go into the eye. It typically tends to go a little bit. So please remember, this is playing with fire. You have to be extremely careful. You have to be ready to flush out the eyes properly. And anyway, just in case, I'm going to be washing his eyelids with saline, bus saline. That. Okay.
Patients, that would be, which period would be your choice, Rajita?
कहाँ? I can. हाँ अब ठीक हो जाएगा. What happens is there. Sorry, I lost you there, but let me just complete this. So sometimes lashes have a little bit of the peel, and that can go in, which is why I like to. Okay. अभी कैसे?
It's not like for everybody we have to flush the eyes after the procedure. It's just that the patient has complained about a little bit of volume of Rajita has done that. She just wanted to demonstrate like, suppose if the patient tells that there is any burning in the eye, or suppose if the peel gets in contact, this is how we would tackle it.
कौन सा लाम
Do you prefer a horizontal supine position, Rajita, because it's cheeks or a
Horizontal is
इसमें
better
नहीं।
actually.
yeah.
Because if it is raised, if it is for slightly raised also, if the head side is raised, there is a chance because NMF light is a liquid peel. There is a chance it can enter into the eyes.
Okay.
And second thing is while we are neutralizing, basically we can do it separately also. You can remove the lower eyelid first and then the upper
चलेगा
eyelid.
कोई एक
So here, like as we are doing a demo, like we had to do it together.
So now my assistant is going to be applying the moisturizer and sunscreen, no steroid creams, nothing. So if I want everybody to note that I sat down, I kept it completely flat because that gave me control. So now I'm going to
There is
move on
no
to
redness in the eyes. You can see the
No,
patient.
no redness.
there is
He's
no
comfortable
redness.
now.
So there is no contact of any peel with the eye.
hello redness
And one more difference that you see with the eye peels with the compounding preparations which I asked is basically the pH varies. So the frost that happens, the effect that comes, the adverse effect that comes will depend on the pH of the solution. So,
So contact time, typically in my patients, if they are well trained and all, you keep it on for 8 to 10 minutes also. But here, the frosting happened in 2.5 minutes, in less than actually. So I finished the whole thing in 3 minutes.
so basically,
If frost doesn't happen, keep it up to 10 minutes. If they're well primed, it doesn't happen actually.
yeah, we have not primed him basically. So if we had primed him,
Rajita,
he has been
even
using
atopic
sunscreen
patients, you
moisturizer,
prefer the
then
same
usually
thing?
we can tolerate it to 8 to 10 minutes.
So regarding atopic patient, you're saying something, sorry.
In atopic patients also, do you prefer the same peel or do you want to?
Now, if atopic dermatitis is there, I would do no peel at all. But if atopic tendency is there, now I am doing this not for the dermal pigment, I am doing this for acanthosis nigricans. So if an atopic person has this, I wouldn't mind because we have excellent barrier repair moisturizers now. So can we move on to the next patient? By the way, before that, there is going to be some peeling from day after onwards, after 48 hours, and there will be visible peeling for around 3-4 days. So his regimen is going to be a gentle cleanser with cetyl alcohol, stearyl alcohol, a moisturizer and a sunscreen 3 times a day. That means 5-6 times a day. We want him to apply one thing or other, but he will wash only twice a day. So a month, 1 month. So these are relatively stronger peels, but this is not a medium depth peel. This is a superficial peel. We have no business doing any medium depth peels. So can I
Yeah,
move on?
one more last
Yeah.
question. If there is only periorbital melanosis, then which peel do you prefer?
So for periorbital, now again we go back to my presentation. What is periorbital melanosis? What depth is it? What is causing it? Again, same old question. So is it ADMH? Is it PDA? Or is it aging? So if it is a dermal pigment, then no peel will help. So that is why we have this device here and we have the corneal sheets here. Okay, so we
And
have
if it is
this.
epidermal pigmentation?
If it is epidermal pigment, then I don't mind doing a lacti. I like it. During tired days, we used to do glycolic peel. But I personally like to do lacti. I personally don't give them packages and all. Lacti peel I do like an add-on. Let's say I'm doing some face peel. I do that also before they have some special event. And I do it like a one-off. There is lacti peel, the 90%. Again, no conflict of interest. I don't prepare any of these, I just buy them. Okay.
Carry on.
Yeah, thank you. So we have this beautiful lady here, and I want her eyes to be the focus now. Can we zoom in? Okay, great. So look up, please. So you can see that she has.
रोक के मैं उसमें करूँ?
हो
गया,
बस
दो मिनट में भी कर तेरा फोन मैंने 2 मिनट
So you
एक्स्ट्रा
can see. I believe there are.
Recently, I think a few of them are supplying. They shared.
Average cost of this product will be
Sorry.
cost.
Cost of the corneal peel. It's not that expensive. Now I don't remember. It'll be some 4,000 Indian rupees. I'm not sure. Okay, so we have this lady. She was 40 years old, and you can see that she has pigment all around. And if you focus, then you can make out that she has static crow's feet. Is it evident on screen?
Yes, yes.
Oh, great. Okay, because in this yellow light, sometimes it can be tricky. Okay, now you can see that this periocular PDL is going all around. She's got some melasma, we are not tackling that. Now, eyes open, you eyes open. So if we really want to improve her periocular area, I would not start with that. I would start with filling her temple, creating a little bit of a open eye look by lifting the brow. So if you do the conventional botulinum toxin crow's feet, it will take care of her. It will help her static lines. I won't say take care of it, and it will help her brow lift. And I would do 2 extra points like how Dr. Ishaq had demonstrated. And then I would want to do for her microneedling radio frequency and wallet. So today I will not be doing toxin, but I will be doing microneedling radio frequency, and I'll also be doing wallet for the periocular area. Okay, like this. So, innovation people have kindly brought their secret duo machine. So I'm going to be using only the MNRF part of it. Okay, though the 1540 would be a fantastic addition. If only we had planned, we would have shown that also. So erbium glass is an excellent idea for these kind of concerns. So this is a MNRF with a 25 pin. Can I get it closer, please?
दो लोग आके
Oh. Okay. Now the depth is going to be key. We spoke about how the periocular skin is very thin. So I am going to be using 0.7 mm depth. Can you help me? 0.7 mm depth. Reduce the depth. And RF, I will keep it at 70 milliseconds. Intensity in my clinic, I would do 40, here we do 36. Okay. And the delay time, we want to keep it double of the RF duration, so 140.
So if
And
you
more, you can keep it faster. Yeah, but keep it straight only. Better not it straight. I want it straight. Okay. So maybe you can focus on this piece. Put it in red. Show something in chest. No. Can you bend below? Little bit more. Okay. All right. So I'm going to start now. All right. Shall I start?
Yeah,
Is the view okay?
was the numbing cream applied, Rajita?
Sorry?
Numbing
Numbing
cream.
cream is applied for 1 hour. I mean, I go. Okay, where is it? Okay. Please let me know if my hand is obstructing or view is not proper. Chase no sugar.
डायोड लेजर डायोड के भी
So, Rajita, can you highlight on the depth of penetration in the
Yes. So we discussed how the total entire depth of the epidermis plus dermis is around 1 mm. So I'm using, now I don't want to go to the bottom of the dermis. So I'm using only 0.7. I could have used 0.8 also, but this lady has rather thinned out skin because of the photoaging.
So the purpose of MNRF is for collagen remodeling.
For collagen induction and collagen remodeling, so that her static lines and her fine lines can improve.
So people who do not have MNRF, can a derma roller with 0.5 mm be an alternative to this thing?
I am not a believer of derma roller. There was a time when it was called poor man's fractional laser and all. I don't think we should be doing this. And 0.5 would hardly do anything except maybe help topicals penetrate a little better. So because it is not the mechanical injury that is doing the job. It is the the temperature increase because the radio frequency energy is going in there and increasing the dermal temperature. So I did two passes if you all have noticed. So I did a vertical and then I did a horizontal. I hope that was evident.
Could you mention?
You combine.
Dr. Monica,
You could combine. You could also combine monopolar radio frequency with this. And one popular thing would be to combine, if you know how to use the corneal sheets, to do a Q-switch yak, and if you have a pico, then typically this much of collagen remodeling, pico itself does. So I don't actually have to do all this.
Yeah,
possible in the
hi. Yeah,
people
you
unit.
gave us a card and
Sorry,
told us to
not
come
the
after 1
possible in
hour.
the pico. Pico's
Yeah,
MLA it's called. That's the micro lens array. Pico laser.
So when are you supposed to come?
So I've completed this pass. Now I'm going to go
Sorry?
to 0.5 mm
Yeah, this is my mom's number. Can you give a call when?
and 58 milliseconds.
Don't.
Delay time would be 100. And I will be doing the next level. So you saw that I did the deepest first, and now I'm starting with the diagonal angle.
Just give us a call, no? Like we'll be coming in half an hour.
Is it clearly visible on screen, Margaret?
Yeah, your hand. Yeah, this is better. Dr. Rajita, what would be the gap that you would maintain between EVDs and the fillers and HIFU and all? Can you just throw light on that?
So
Somebody has a filler or some for whom you have planned for HIFU and filler. What is the gap, or would you do, would you not do?
So I certainly would, but I would give the filler 1 month to settle down and get incorporated into the tissues. So once that is there within the tissue, then your devices, your energy-based devices are not going to melt it. It is not some paraffin wax that will just melt off. In fact, there are some studies which have shown that HIFU and filler combination is synergistic. Now, I want to draw the audience attention to the fact that first I did the vertical and horizontal, and here I am doing a diagonal and a reverse diagonal. I don't know if it was, so I did a horizontal, a vertical, and then later on I did this, and then I did this, because we don't want the needles to go in the same places again and again. So that should do. Normally I would do a 0.8, a 1 mm, a 0.8, 0.6, depending on the skin thickness, or I would do a 0.9, 0.7 and 0.5. So those are only 2 classes, because I will be doing the volite test then. So any more questions about this?
Yeah. What are the any side effects we need to think about this procedure?
One, this can be a very painful procedure. It's not so painful today because periocular skin is thin and the anesthesia is actually working, but normally it's very painful. And microneedling radio frequency is not generally known to cause a lot of TIH, though it could. And because we like to use our amide anesthetic with tetracycline, lots of times the topical anesthesia causing PIH is more common than the MNRF itself causing the PIH. So I am going to be doing now the volite for her, and then I'll come there. Okay, so we can send her off.
And in this procedure and this ablative RF, we don't have to be worried about the eyes, right? We don't have to.
No. For radio frequency, we don't have to worry about the eyes.
Yeah.
So, thank you so much for keeping this. Now, I have changed my gloves and I'm wearing sterile gloves because I will be doing volite. Volite is the same thing that Dr. Mickey Singh demonstrated, but I will be doing it only for the eyelid, for the periocular area. And I will also be showing it on the forehead because I've got 1 ml, and I'll be talking about how we can avoid vascular accidents while I do it, because that was something that was left out since morning.
So, Rachita, before I do the fillers, like how about the role of boosters in this area?
Sorry?
Role of boosters, skin boosters in
Yeah.
rejuvenation surgery.
So role of skin boosters would be to improve the texture, improve hydration, and improve elasticity, all of which this lady would benefit from.
But the following is the structural defect will not.
The structural defect, and if you observe carefully, she actually doesn't have much of a structural defect, you know.
No, but generally.
Yes, absolutely. Skin boosters can cleanness and skin మండుతుందా కొంచెం మండుతుంది Now we all have our local anesthesia skills. Now I want to bet much higher. Please put them to good use.
Dr. Esther, here for demo purpose, you are doing MNRF and Volite together.
Yes,
But in
no-
your
normally
clinic,
I would.
yeah, in your clinic, how would you do it actually?
Normally, I wouldn't mind doing my Q switch here and a filler, but generally I like to do it on separate days, like Dr. Isha was saying, because what will happen is it's not a big deal, but it will be burning. Now I'm putting sterilium, I'm cleansing again and again obsessively. So you can imagine that I'm putting her through unnecessary pain. Sorry, but this was a little unplanned thing because one of our volunteers did not show up.
मेरा हाथ आंसर रखिए अच्छा
And there might be some temperature changes in that area, no? Will there
I'm
be-
sorry?
There might be some temperature change in the area.
Some temperature changes would definitely be there, but that will not affect the hyaluronic acid integrity at all. So all these products from Juvidome at least have been tested at various temperatures, and that should not be a problem. But that's an excellent thought and excellent question.
So Volite should be the last procedure should be done, Rajita.
Actually, if we had to do a toxin, that would be the last. But for this lady, I thought we can spray her after this.
After completing all lasers only, we have to go for Volite or
No, we don't have to complete them, but for that particular day.
चेंज है
For one particular day, you want to start with the deepest. So if you want to do a voluma, a vollift and a volite, and in case somebody is thinking all this is Greek and Latin, please pardon me, we'll sit and talk about all these things. Again, no conflict of interest, though these products are sponsored by Allergan. So voluma is a high G prime filler, equivalent to your Restylane, somewhere less than Restylane if you can think of it. So whatever is highest G prime you want to do first, whatever is lowest G prime you want to do last. Now this one has the least G prime.
So even after the filler, you can.
I'm asking about the laser. MNRF, after completing all MNRF sessions, then finally we can plan Volite or
You don't have to. You could do off one volate that will act for 9 months, and then you can keep doing because the MLR will be multiple sessions. Okay. చిన్నగా ఇంజెక్షన్ చేస్తాము భయపడిపో సరేనా ఆల్రైట్ ఒకసారి మంచి స్మైల్ చేయవా ఓకే కెన్ యూ సీ ద క్లోజ్ ఫీట్
Yeah, a little bit closer. The camera should zoom in a little closer. Yeah, now it's good.
ఓకే
So could you tell us at which angle you will go into the skin because it's different from that of cheeks, Rajita?
yes because the skin is thinner so I want to keep it at 10 to 15 degrees I want to stretch nicely and ideally I would like more light I think we forgot to get extra light correct okay you will show that చిన్న ఇంజెక్షన్ చేస్తున్నాను ఈ షేప్ కింద పెట్టుకో క్లీన్ okay now can you see those lines there the upper crow's-feet area
Yeah, it's
okay now I'm starting this is less than 10 degrees and I deposited some can you see a small bleb there very small
also the quantity, like how much are you depositing?
I am going to be doing 0.01 or less per point. Okay? She's got very thin skin. That's it. You're not going to be seeing anything today. Her results will be evident in a week. They'll become better in 2 weeks. This is almost like microbotox. I tried my syringe and after doing this, I'll still have probably 0.9 or more. Can you make out that I'm doing a little injection there? On screen?
And the sequence of moving from lateral to medial is to make sure that there is anesthesia already setting in.
That also helps, yes. And it is trickier to do medially. Now, how close can you go? These are tricky things. Another time people must be getting palpitations here. They can sit down. Very small blebs I'm doing. There's a very high risk of a bruise. I already caused one. But generally in the clinic, when you have good visibility, when you can see your vessels, it will be better. You have to prepare all your patients that they're going to be bruising, especially if you're doing anything in the any injectable in the periocular area, including Botox. But this bruise is not a problem. It will go off in 2-3 days.
The chances of Tyndall effect here, Rajita?
I'm sorry?
Chances of Tyndall effect.
Tyndall effect with this, no way. Whole life does not cause Tyndall effect, and you see how much I knew. The whole life is something that is meant for intradermal use. But can you make out on screen that the moment I kind of flatten it, it's going off? The bloods are going off. Can you see that?
The way you're stretching it is making it easier. I think thereby you can avoid all the superficial capillaries.
So far, I have used around 0.05. Now here, as long as you're in the intradermal plane, you have nothing to worry. But in these areas, relax. If you are not in the intradermal plane, this is very knee shoulder down, relax, get very good. In these areas, these are risky areas. Now this does help in improving the transparency of the skin as well, because obviously it's going to add substance to the dermis. Each molecule of hyaluronic acid is going to bind to 1,000 molecules of water, they say. So that's, you can imagine how that would make the crinkliness, the static lines and the even the dynamic lines look. Now I'm going to kind of go beyond into the lateral crow's feet area. The bruise is nicely darkening. Can you make out that my injection angle is very less? Is it visible on screen?
Yeah, it's
It's almost tangential. Now, in case there's a bleb which is not going, that means we'll probably have to high lace. Though I would wait for at least 2 days. Once in a while, we will have to high lace in this area. A lot of people don't like to do because they're scared that they will have to call the patient and high lace. But it's a very gratifying thing to do. So this is another to do. I'm going to get gloves in them. Just press this. Because sometimes you can have bad bruises. So I've done this eyelid and I'm going to do the forehead now. And I need better light.
Engineering, can you brief the points when we should highlight Rajita, like, is it the persisting swelling or the increasing in the size of the swelling?
Sorry, there's so much of crosstalk that I cannot. No, what about what was your question again? Sorry.
No, you told you'll be waiting 2 days before highlighting. No?
Correct.
Is it the persistence of the swelling which is an indication for the...
Correct, yeah. See, you want to, see, there is a lump, you want to highlight. And of course, if you are, now can you make out the depth of my needle?
Yeah.
Can you see that it's clearly intradermal? Now, none of this is for beginners. Once you people are very comfortable doing the cheeks, then you can do this. Because if you are not intradermal, then you could be inside a vessel. Can you make out that small blebs are created and then immediately I'm flattening and they are going off? Is it visible? Sometimes when you're doing this, you have a linear flow and there are beginners who thought that it's gone into a vessel. So that's not the vessel, that's just the fibrous septic. So don't worry. Now you will make
What is the
out
indication you are doing, Rajita?
this is for her texture, hydration and elasticity. You can make out that she's got a lot of static lines. Can you make out that on screen?
For beginners, would you advise to make
And
grids on the forehead?
dehydrated skin, poor skin quality. Sorry, Rekha.
For the beginners, would you advise to make grids on forehead like
Yes,
that?
yes. Totally. Now, you can see that I have not drawn grids, but I am going in a very systematic manner. And so far, I have used 1.15 ml only. 0.15 after doing this eyelid and almost half the forehead. Now, normally I would put around 0.02 per point on the forehead. But for this lady, I am putting less because she's got very thin skin. So you will have to tailor your electrode volume to the thickness of the skin. So you can see that because of the edema, already the fine lines and the static lines on one side have gone. That is a temporary effect. Now you see that I am supporting my hand. Is that evident on camera? No, so do this. Now can you all see that?
No, we can see the stretching and all, supporting finger is not.
Okay, maybe the camera can zoom out a little because I want people to notice it.
So what is your opinion on doing a PRP instead of a filler in a similar pattern, Rajita?
PRP, I know I am not a great fan because if somebody doesn't mind the cost, if you do this, you don't have to repeat for 6 to 9 months.
No, for initial
Yeah, but-
this might be, PRP should be a more safer procedure, no? Like probably-
No, PRP is not safer. You know that there is a blindness reported with PRP? Is the audience aware? How many people in the audience are not aware that PRP can cause blindness? It's been so PRP is as safe or as unsafe as a filler in the forehead. In the scalp, it's very safe, of course.
Can you elaborate a little bit on that statistics, Rajita, like PRP on the forehead and how many cases have been reported?
As far as I know, only one, but one is enough. Now you know that most cases are not reported, but please be careful. PRP is a definite option. PRF, I think, is going to be a fantastic option as well, and probably to give you longer lasting results. So you could definitely do that. See, basically, PRP and skin boosters are done for the same purpose, to improve skin quality, to improve hydration, to induce dermal collagen. So you can definitely do that as well.
I think you mentioned about the fat fillers in your presentation, Rajita.
I mentioned fat grafting, yes, I did.
So,
So
is it safer?
it's not safer, no way. Fat is much more tricky. The problem with, in fact, there was a slide on complications of fat, but I did not elaborate on it due to lack of time. So the problem with fat is, you cannot reverse it. So you have to underdo and you have to align your patient for repeat sessions if needed. And you know that there are as many cases of blindness with fat as there are with fillers. And obviously all the fat injections were done with cannulas, none with needles. So just because we are using a cannula does not mean that it is safe. Now I have
Periorbital regeneration, recently there is introduction of the threads.
Yeah, now the threads you people only have to talk about. I don't do threads. I am not a great fan, so please elaborate on it.
Next Cuticon I will tell you, Rajita, about threads.
Okay, so everybody who is interested in threads, please register already.
Doctor, the time is 4 o'clock.
Okay,
So-
so now I think we are done with
Yeah.
this. We're going to be moving on. We have only the periorbital fillers left. We'll have to ask Larry sir if we can take what, 20 minutes more? Ask. Or the problem.
Sir is not here.
I think if we can get 20 minutes more, we should be able to finish.
Go ahead, Doctor.
Okay, so now I completed 0.7 ml, I did 0.1, 0.1 and the rest 0.5 I did on the forehead. So what I'm going to do is, I'm obviously not going to waste this. I'm going to do a in the adjoining upper cheek. Here my angle is a little higher. Can you make out that? 3 points are
Around
here.
10 to 15 degrees in your forehead, but here it's approximately 30 to 40.
Yes, yes. Because your skin is thicker. I hate wasting fillers or bullet. They're expensive things.
Are you going to demonstrate CK3 also?
In the other lady. Okay. So this one is done. I usually. Okay. Thank you so much.
Any questions
So
from the
now,
audience?
okay. Okay, one. Please take a look. This is a bruise. A bad
Can you
one.
focus on the bruise area?
Yeah, please focus here. You see that? It can be seen?
No.
Okay. So please don't worry. That is a part of the deal. Okay. So now I want everyone to notice that this demo has been done with utmost sterile precaution. This was my sterile area. You saw that. Once I wore gloves, I didn't scratch my head or adjust my hair or do anything like that. And I had assistants to hand me stuff. Okay. Take out. So now we're going to come back here, and for her, she's already beautiful, and now we're going to make her even more good looking. The plan is to use a high G prime filler voluma
हाथ में देखो ना
in the zygomatic arch,
कॉफी
point,
चाय
point one
and sandwich.
inch microperm, bolus in 3 points, and then I'm going to do 0.2 in the medial zygomatic area, also known as the CK3, and then I'm going to be doing the tear cuff. So I'll be marking. First, I'm going to be
I'm stopping this.
Using 2 ml.
only one side I do on camera, then validate, then Dr. Sudhavani can start off, and I will finish off off camera the other
पिलो
things.
ला दो
Sorry, Dr. Wilson.
You are using 2 ml, right?
Yes, I will be using 2 ml.
Which products are you choosing? Like,
So we have voluma here, and we have volbella. Okay, and where's my tray? Great. Okay, so Dr. Pranita has already cleansed the entire face, not just the area of concern, but the entire face. So now I want the pencil paper. Okay, you see. Now the cheek points, zygomatic points, I will be using the needle. I will be using a 27 gauge needle, and the tear trough I will be using a 25 gauge cannula. You can try. Your gloves is correct. Okay. You can try and keep. And I'm going to show you all a technique I use to mark in a relatively aseptic manner. And I want this bit much higher, please. And this is a marking, okay? Can you go on this? Great. So I like to do the marking after the cleansing. I'm feeling for the suture on the zygomatic arch. The suture is here.
इसलिए नहीं लगी
So I'm going to be doing upper and lower borders, and I will do.
Rajita, can you just move the gauze piece to obstructing it?
Okay, no, but it is keeping my pencil sterile. So once you, okay, is that fine?
Yeah.
Okay, now look up, please. Look straight. So this is I'm looking for the
बताएं
medial limber line.
हम process देखने दो मम्मी
Is here. And why am I doing that? Because that is the area where you have the infra-orbital artery. So I want to avoid that, and I am going to be doing my injection into the center of this. So that is my no-go zone and this one. Then I am going to be doing the tear trough. So I marked out the orbito-malar junction, the lid cheek junction, and I am marking out the tear trough. So on the bone, I will be depositing the volbella. So now I will.
Dr. Esther, you can just turn the patient's face once so that the zygomatic arch markings can be seen easily once.
Is that okay?
Yeah. So those are the CK1 points on the zygomatic arch. 0.1 into 3 points, 3 bolus.
नहीं
I
कॉल
think
करती बोलो
I will
मैं
need
10 मिनट में
maybe
आता
10 minutes or less, and then we can have Dr. Sudhavani's talk. Did you try, Karika? do it? Okay.
हम पे जाके करा लो 1 बजे तक
You will have no. I already do.
5 o'clock is closing time.
Ready? I'm now going to the
Go man.
marking.
ठीक है ना खाना
I'm doing perpendicularly. I'm on the bone. I'm doing aspiration. And I'm going to wait for 15 seconds.
पहचान लेते कोई भी
And now I'm going to be injecting. Why is
आगे तो बोल रहा है आई विल
everything
phone along.
visible?
मैं इसमें देखती हूँ हाँ
And I want to get even higher.
Can you move a little bit because
You can turn her towards.
What do I do? Oh yeah,
Just turn
she
her
wants you to zoom out. Then
She looks fine.
You understood.
She probably
Turn her face
gives
towards the
butterflies.
Towards her. Yeah.
सामने से करवानी है
Okay.
ओके नो प्रॉब्लम
Okay, I want everyone to see how
ये
I'm
भी आधा
doing
घंटा
this.
चलता है टेक योर टाइम
Shall I do it?
सुकून से do.
So,
Ready? Shall I? Come to now.
yeah.
Ready? I'm on the bone. Aspirating. Single hand aspiration is something that I would strongly encourage everybody to learn. Makes life easy, far easier than double hand if you ask me. Safer. Less chance of you moving after you aspirate. My patient is comfortable. Now, third point. Ready. On the bone. Stabilized. Fifteen seconds. 12 seconds is enough this year. Done. So I have completed the zygomatic arch 3 points using the needle supraperiosteal plane. Now I am going to do the medial malar supraperiosteal injection. Close your eyes please. Ready? Small injection. It may hurt. Perpendicular. I felt the resistance because this needle has become blunt. Counted 15. I'm waiting a little more. And now I'm going to be doing the
How much did you inject here, Rajita?
I injected point. So it's important when you're planning these things to plan your syringes. Okay, wait, what happened to that? Now I'm going to take the valvula and I'm going to be fixing it to my cannula. The cannula please.
for beginners, do you recommend to do both sides the same points and then get back to the valvula, or do you want to
No,
finish
no, I
on
think
one
you
side?
can do, but I would strongly recommend that you finish marking simultaneously. That's something I did not do now because of lack of time. You don't know this, that's not stable. Okay, now sometimes patients get a little scared when they see the cannula. Now you can do this. Priming needle. Imagine. Okay.
Now, which is more safe, Rajita, to use a cannula or needle?
Generally, cannula, thin needles are safer, thick cannulas are safer, and for the theatre, definitely this is safer. Now, I wish we had time to sit, to make a sit up and admire, but I'm not going to. I'm just going to show the audience how to plan the entry point. Okay, so is this visible?
Yeah, it's just.
Okay, so you want to go till there, right? And you also want to go till there. So this point would be a good point. Still, I'm going to need maybe 2 minutes and then Dr. Sudhavan's CV and all can be ready. Is everything visible on camera? I'm pinching hard. Small poke. Widening it. Dr. Pranita is wearing sterile gloves and she is removing the introducer needle. Please remove. And I am in. That's it. And where am I? I am just beyond the orbital retaining ligament. And now where am I? I am in the theatres. So unfortunately, I could not demonstrate the gift that was felt. But can you make out this? I am tenting so that I can show you all where I am.
Yes.
Is it evident?
Can you point the tip from which is
Here. Yeah. Please observe here. Is it evident?
Yes.
Huh? Okay. Now I'm going to start. What I'm going to do is I'm going to go from here to here. Open your eyes, please. Look up. So just between the limbal lines, point 2. Lateral part, point 2, and medial part, point 1. Close your eyes. So that is nothing but TT 1, 2, and 3 respectively. And the technique I'm going to be using is micro helicodes. Okay? And not rushing to do it very slowly. So we were talking about which one is safer. So actually the choice of needle or cannula should not be based on whether you are a beginner or you are experienced, but it should depend on the area that you are doing. So if it is a deep temple injection, that gunshot method, whoever you want to do with the needle. The zygomatic anchor points, like I just did, those you want to do with the needle. Whereas, if you want to do the deep medial chick fat pad 0.5 and all, then you want to use a cannula. Because if you're doing a bolus, please don't exceed 0.3 in any one place. Even if you are not intravascular, extravascular compression can happen. Because it's going to get hydrated.
Is it better to do antidiabetic deposition or retrograde?
Now with micro.
Any questions from the audience?
Are you doing any substitution?
No, I'm not doing any substitution. We have absolutely no business doing any substitution in theatre and all. I think that's a very bad idea.
Dr. Rajita,
Yes.
would you tell the comparison between using wall lift for the tear trough and wall bella for the tear trough?
Wall lift-
Which one would you prefer and why?
Wall lift is not actually licensed for the tear trough. And if you have a very deep tear trough, then I don't mind. But for her kind of a tear trough, it will be a disaster. You will end up with too much swelling and tingle. So, because you understand that the concentration is much higher, Volbella has only 15 milligram per ml, which is why tingle effect tends to be less. And please don't aim for 100% correction. Now I'm withdrawing. Please observe for the give. I don't know if it was evident. And now I am going to the medial tear trough. Is my cannula evident?
Can audience see that? Where the cannula is?
So the advantage of cannula is that you can go that close to the medial part. And now I am going to be doing micro liquids in a linear fashion.
Dr. Rajita, would you like to aspirate even with the cannula?
No. Aspiration makes sense if you are going to stay at one place. Now, each point of the cannula, do you want to aspirate? Is there any point in aspirating only the first entry point there? So it doesn't make sense, right? Advantage with Volbella is even if there's a little unevenness, and I'm going to show you how I would mold this. Little molding I'll be doing. There's a bit hasty there. I'm done. I have injected 0.5 and I'm going to just show you how I mold. Do we have it? Yeah, great. And I brought this, no, don't touch it. Please don't touch it. This is a tray I got from Europe, so that if I'm alone with a assistant who is not trained in wearing sterile gloves, I can do it in a sterile manner. So we need to invest sometimes. And I have a sterile Q-tip here, and I'm
Dr. Rajita will proceed with the other half. We'll start
Yeah.
with the next talk.
yeah. Like,
Excellent, Dr. Rajita. You have
We
made
can
so
ask her
many
to sit
points
once,
here.
Rajita. We can ask her to sit once. The camera
Yeah.
will be zoomed in once.
So can you make out something or should I
Her
show
face is
after?
little cross.
Sorry?
Her face is a little cross actually.
Chin down?
Chin down, yeah.
Okay.
Zoom.
Yeah, you can see that the
Straight.
shadow is completely gone. Look straight, please.
Straight. Camera straight. Camera is at the angle. Yeah, now you can see.
The tear duct is around 60%, 70% corrected, which is what we want, so that once it's hydrated, it becomes 90 to 100%. If it is 100 here, it will become 130%. And then you have to hydrate. And also I want to turn to the side. And no, not like that, completely turn. The camera has to adjust. Not just lower, I want to profile. No, so can you make out the medial cheek?
Yeah, it was flat before.
Yeah. No? So maybe we can turn on this side, turn this way please, so that you can compare.
Yeah.
Okay? Yeah. So, the mic
We'll
can
go
be-
in with the next talk.
So now we move on to next topic, skyboxy therapy by Dr. Sudhavani. Welcome Dr. Sudhavani. Podium.